I think I don't need this paper here, because I will point out for you, as a nearly called senior ranking officer, grandpa of 2 grandchildren, what I did in my career before joining the Air Force. 20 years of the hospital, and 10 years of aerospace medicine now in Fürstenfeldbruck at the Institute. In the preparation of this talk, I got an email from AD Davenport. Somebody has to argue with Christoph, and I asked him, are you searching for beaters? No, as you did hear from my colleague Pipik, we are friends, and I did take this picture in Fürstenfeldbruck at the Officers Club, 2 hornets, like invasive cardiologists to cardiovascular surgeons. But what we have to beat is cardiovascular incapacitation and death. And so this is a German newspaper a few days ago, this year in February, statistics of cardiovascular death in comparison of 1990 to 2010, plus 31% of cardiovascular death. Unbelievable. What are we doing in cardiovascular management? And what are the results? Continental Airlines was not happy about this information that this pilot in command died during rotate. Would you be happy to sit in this plane at this time? The complaints of this pilot you can follow up in the cockpit voice recorder, and also it was documented the cardiovascular problems, the infarction on the ECG on board. And what we know, we have a changement of opinion and science. We have to change our mind from degree of stenosis to plaque burden and plaque localization. And so you can see the minor coronary artery disease leads up also to cardiovascular death. And what about 1% rule? And the autopsies at the FAA, 600 dead pilots within 2 years. And these are not only the grandpas of Anchorage who are dying, only 1/3 of them had no coronary artery disease. And by definition, coronary artery disease is angiosclerosis of the coronary artery. It's with or without higher degree stenosis. And the same we had, if we are looking back in our history at the Institute, that is a publication last month in the Blue Journal, although we had only one third without cardiovascular angiosclerosis. The regulations we are acting on, we had a new order since last year, 0 loss. Prevention of loss of failure of the operating personnel and airframe. 0. We will not reach this point, but we must try to get close to this order. And also we have our Grey Bible, as we call it in the German military, what we have to do. And what we are doing is annual stress ECG and ECG at rest to look for the cardiovascular circulation. And above that, we use additional examinations like ergospirometry. Our annual order to do for every airman is anthropometry to look for the body mass index and with a special detection of visceral fat by bioimpedance. And also, as you did see before, lipid status, blood sugar, and also what we are doing, routinely screen the vessels, the abdominal aorta, and also carotid intima media thickness as a risk factor. And at least ECG at rest and bicycle stress test to the maximum effort. We want to have a maximum effort. We don't look in the first line up on the pulse work capacity. The civil regulations are the basic. We will not step beyond the civil regulations, and as you can see here, minor asymptomatic coronary artery disease is not a ground to pull them out of the cockpit. And the new regulations also order in suspected asymptomatic coronary artery disease, the first step is exercise electrocardiography. But ergometry, is it all? If you use stress ECG, we get on a cheap basis a lot of important information. The first is pulse regulation. Is there a stable sinus rhythm or some other problems? Also, we look at the blood pressure before, during, and after stress. And besides that, premature ventricular beats, the fitness, pulse work capacity maximum, and beside all, especially in the elder one, we look on coronary artery disease, potential ischemia. It's a standard procedure, and just 2 cases to look on it. This was a fighter pilot, fit. He had a maximum pulse work capacity of 4.1 watts per kilogram body weight, and he lost consciousness in the recovery period after this maximum stress due to atrial flutter and due to an atypical Wolff-Parkinson-White syndrome. The second one was last year a flying flight surgeon, helicopter flying flight surgeon. We are able to compare these ECGs from year to year, and he developed this, what you see in the ECG under stress, asymptomatic, fit. You are biting me. He underwent nuclear stress test. Nuclear stress test was normal. And at the end, he underwent cardiac CT angiogram to exclude coronary artery disease, and at the German Heart Institute in Munich, they found an occluded right coronary artery with insufficient collaterals from the left side. So, over the years, we can compare every year the stress test ECGs and see some slight changements. And that's our policy, what we are using since 2003, since 10 years now. Significant new ST segment suppressions or new ventricular rhythm disturbances of higher degrees lead to exclude coronary artery disease at the German Heart Center in Munich, which we have a fixed comparison. And also to talk about costs, that is a special investigation the same day the pilot is in Fürstenfeldbruck and costs $370. But calcification, is it enough to exclude coronary calcification by CT scan? If you exclude coronary calcification, your risk to get an incapacitation for cardiovascular symptoms of the heart is very low. If you accept a false negative result of 4% if there is only soft plaques. CT angiogram. If you are using a 64 slice CT machine or above, that's enough. You are in the high 90s for sensitivity and specificity to prove or to exclude coronary artery disease. And the negative predictive value is the highest one, nearly 100% now. Always the discussion about radiation, especially in flying personnel. There's a big study, multicenter, multi-nation study, and you see there is a mean dose of 12 millisievert going up to 30 and more millisieverts per investigation. And if you're using the right machine, if you're using the right software, you can now perform CT angiograms below 1 millisievert. Especially, I had a suspicious ECG myself. When I've been 40, I had to undergo invasive coronary angiogram. So I know both active cath and suffering cath on one side, and when I joined the Air Force 10 years ago, always my ECG was suspicious, and though I underwent myself cardiac CT, it's very more comfortable than a cath lab, I can tell you. And in my person, CT angiogram was done with 0.8 millisieverts. If you calculate above localization, window and calcium scoring, all was done in my person with 1.2 millisieverts, and now in the last 2 years all CT scans we are performing at the German Heart Center in Munich are done below 2 millisieverts, and that means below a normal angiogram. Just, Eddie, one picture for you, for argue. What about ischemia? If you remember the picture about CT angiograms, 90% plus for sensitivity and specificity. If you look here at the stress echoes and the nukes, and although the perfusion, you are much lower than 90%. Small numbers. If we are looking at our own numbers since 10 years, that's more than 100, about 200 now. Is it validated? The confirm register is a big register, also multi-nation, multi-center. They are looking at more than 32,000 scans now, 32,000 subjects. And out of them, a special group is identified asymptomatic. This group is more than 7,000 subjects. And if you look at the results, there is one clear, better pointer. I will show you here. If you look here, there's a native vessel coronary artery without any plaque. And important is here, these two, obstructive one vessel disease and non-obstructive coronary artery disease, are close together. And if you compare this in the future, you will see, and combine that with the information you get from a coronary artery risk score, these sticks together, obstructive one vessel disease to angiosclerosis, and the published data look at follow-up of 2.5 years, and at the German Heart Center I got the information they have the first group looking on 5 years now in this register, and it becomes more and more clear that non-obstructive angiosclerosis and one vessel disease are sticking close together with the risk. Aeromedical disposition. The practice guidelines for coronary angiogram since 1999 in an expert consensus recommend angiography in persons with a special regard to safety of others like bus drivers and pilots. And I think today we have a better possibility for angiogram that is non-invasive by cardiac CT scan. Our results over 10 years show that we have 1.8% of suspicious stress ECGs. And if we are looking at our results of cardiac CT, we have a calcium scoring like you can read here. We have excluded coronary artery disease in 80% of our population and proven angiosclerosis in 20% of them. And there we found up to asymptomatic two-vessel diseases with 90% stenosis. Important is, and that is some kind of politics, if we are accepting in the future 6.3% without calcium who have a higher degree angiosclerosis with mild stenosis. I did know that a young, dynamic assistant professor of cardiology is coming and speaking after me, Eddie. For that reason, I did look at the newest book available, and I think we don't have to argue. We have to wake up, like this bird in front of my house, and we have to look at the newest book, The Heart. Radiation-free angiogram, magnetic resonance tomography is not the best one to get to the results we must have. Only 80% sensitivity in vessels who are more than 2 millimeters wide. CT angiogram in this book shows that we have stable image quality with 1 to 2 millisieverts for the investigation. We have a very high sensitivity and specificity, and I think if necessary that is a great tool in our hands like the other methods for handling coronary artery disease. Routine stress ECG is not useless. We are using it every year, and by comparison over the years of the ECGs, we can react on slight changes we see. We clarify we exclude coronary calcium if that is zero for the future potential policy will be that that's enough exclusion of coronary calcium. If we find coronary calcium, the next step will be in the same session the CT angiogram. CT angiogram allows 100% exclusion of coronary artery disease. It's non-invasive, safe, and as I had to feel, it's comfortable in comparison to the other. Plaque burden and plaque localization is important. We cannot tell the truth about plaque morphology at the moment, but I think as we have to change generations of cardiologists, as we have to change mind from stenosis to plaque, we have to change from plaque morphology for the future to prevention. That's the most important. And so you can contact me by this email address if you have further questions from home. Thank you for listening to me.